So first of all, thank you very much for offering me this honor and opportunity to talk to everybody. And one thing I want to correct the introduction. So I matched to North Shore LIJ, previous LIJ, Allergy and Immunology Fellowship. And that was a research track. I found out I was not a research person. So I just quit my fellowship, then became a attending in Chinatown. So several things I think such a great morning, and we heard Dr. Kang, Dr. Zhou talk about the match, the residency, and the time flies. I can still recall how nervous I was when I was applying for the residency on the way from Tennessee, Memphis to New York. And that was a very windy day. My husband drove the trailer, kind of. We put the car on the back of trailer, we rent a U-Haul. And then I was expecting my younger son, little one, and who already became a volunteer and as a 11th grader outside. And also my older son, Ethan, standing back and just came to support me. Thank you very much, Ethan. And so I think I think I really appreciate that Dr. Lee came to me before and asked me to become the ACAP, one of the board members. And they said, "Oh, Dr. Liu, you work very efficiently. You are very fast leader, and so come to ACAP." So that's, I think, it's the time for me to work for the community and also do the development of the educational work for the younger doctors. And I think I graduated from Harbin Medical University and to the OB Gynecology master degree program, and then worked in the first affiliated hospital in Harbin Medical University in Harbin, and then so that was a very great position and opportunity for me to get to know people and understand the women. So, but I don't think I was the person who want to take the red envelope from my patients. So I decided to go abroad. And then after 3 years postdoc, like many of us here, and work in the research lab, and found out, okay, one day the clinical work should be my lifelong career. And so after the study and come to New York, so work in Jamaica Hospital. And I still remember how cheerful I was when I received my step 3 score. That was in the before Christmas, and as my PGY2. And so I prepared to match either cardiology or allergy, because I did my postdoc training in cardiology division. And then, but I happen to know a very great allergy National Association president, Dr. Yoon, who is a Korean professor, and who always so encouraging and encouraged me so much to pursue the clinical career. And then I think, okay, also allergy is a very easygoing specialty probably. And so I applied for allergy and got a pre-match. And so somehow I want to tell the new, younger, beautiful face over here, the attendees. And so to choose a lifelong career, it's really, you need to really think of what you like the most. I think I like medicine the most, although I cannot become a cardiologist, but work in the internal medicine field as a primary care physician made me feel very cheerful every day. And also, when I look at the patient eyes, I found out I can use my knowledge, energy, and affect people's lives, not only treating the patient, but also change their life. And this is an energy mutual exchange. I got the energy from my patients, and the patient got my advice. And so this kind of mutual exchange made me feel doctor is not only it's such a wonderful job, not only making money, and then come to the money, then we have to talk about money, because without money, what can we do? And so sorry, this is not an introduction. And but anyway, the slide we talk of the value-based healthcare. Value-based, in summary, value, money. Period. So and then what can we do in dealing with the money and in the area of value-based health? I will give everybody certain things introduction. Next slide. Okay. And the value-based health is an emerging model that prioritizes patient outcomes and the quality of care over volume of service. This shift from fee-for-service to value-based reimbursement aims to improve population health, reduce costs, and enhance the patient experience. So this give us maybe let me do a survey. How many attendees here are kind of PG 1 or 2 in residency? How many? Okay, 1. 2. Okay. How many people here are going to apply for residency? 1, 2, 3, 4. Okay, 4. And how many people are medical school students? Okay. How many youngsters are going to go to medical field? Okay, 2. Okay, wonderful. So this is we have to know, you have to know money. And I didn't know money at all. And my husband handled my bank account. If I don't know the password, it's a no, right? And but I spend money a lot. And not only buying the thing I love to wear or carry, but also practices. And so I will show you certain slides. And one thing I give you certain things. I do both internal medicine and cosmetic medicine. And because I love dealing with women. And also I think I really want people feel happy and be pretty. So and also I think the medical field, we all know that as medical doctor, you really need to have the this kind of IQ, intelligence, this quotient, right? And then quotient or quotient, I forgot, but IQ is so important. Then EQ, and to match. And Dr. Joe and Dr. Khan already talk about it's so important of your EQ, interaction with the attending, and know how to even dress up. That's nothing. We are nowadays they talk about the organizational cue. This is a quotient, which means people can absorb knowledge, learning, gather information, and put to your mind and to communicate. It's a even trained behavior. And now there is another quote, it's beauty cue. And so which means make yourself be attractive. So even as a doctor, we really have to be attractive, because even when we have to dress the suit, even we dress clean, the tie, but we won't convince people we are serious, we are professional. And also we want to prove people we are knowledgeable, confident, and strong. So this is we do medicine. We used to focus on what can I do? Next slide. Okay, and this is for the young students and the residents may not know what mean of fee-for-service and our value-based care. So fee-for-service is patient based on the number of service. For example, every day we see 30 patients, we charge 30 patients. And regardless of you have 100 on your patient panel or 1,000 or 5,000. So which means even if you want to start your new practice, you can have 10 patients. You can still make a lot of money because you can ask them to come every day or every week. But is that a good model? Maybe it's good initially, but nowadays nationwide it's already come to the value-based care. And so fee for service can result in price inflation and the redundancy of care. So which, for example, I can ask patient come to see me because of just see a normal result. Why? Because I talk to the patient, I still need to charge the patient. I want to charge the patient, but I feel embarrassed because the result was normal. But fee for service, I really need to have the reimbursement. And this can lower the patient satisfaction. Obviously, patient came waiting for 1 hour, even 30 minutes, and spend the fee for the MTA, and okay, you just tell me it's normal. And no reward for the quality of health provided. That's a typical fee for service. And then jump to the value based. This is a payment based on the quality of the care provided over quantity. So what's the meaning of value? Value, which means value is a relatively comparing word. It's compare. So one item over other item, that calls value. Value always come from comparison. So this is come from the quality over quantity. And can bring down the price of the care for individual patients. At least save the MTA the ticket, right? And at least save the off hour to come to the office, and can improve patient satisfaction. Many times I talk to patient by phone. We have lots of fee for capitation patients, and I probably is in New York Chinese community. I have the most fee for capitation patient as a primary care physician in our community, because only render previous Excelsior and have the fee for capitation payment schedule currently. Before, Affinity Insurance used to give the fee for capitation, but later on they terminated because most of the physicians were against this policy. And they like seeing patient, get the money, seeing the patient, do procedures. And so then nobody want to do, especially the other organization, IPA, they didn't support that. And come to the Excelsior, why use previous, not use former or X? I think former or X means somebody already divorced, already passed. So I use previous, which means Excelsior. The whole theory is still ongoing, and the business is still valid. So this is a Excelsior Integrated Medical Group, founded, I think maybe 9 or 10 years ago. I joined Excelsior more than 5 years ago. So I already be a person who got benefits from fee for capitation. And then the era nowadays is already come to the value-based era. Next slide. Okay. And this is another word for explain that table, the comparison. So we focus on fee for capitation, focus on the this is the quantity and the number, the volume. And we focus on the patient health, well-being. You know why? Why? Because the quality comes from our work. If we, as a primary care physician, I still very appreciate all the specialists because they help us to treat the patient. But as a primary care physician, I believe 3 of you may apply for medicine, right? And the medicine is a field. If you are able to treat any patient in your capable knowledge and experience, surely you can do. For example, I treat a patient with dysmenorrhea and the irregular bleeding period disorder. And also I consult them for infertility. And also my husband, who used to be a surgeon in China and do lots of suture for the patient and save the patient time and money. And so this is what we are doing. And this is the beauty of the system in US. And so I think we all appreciate the system. And then come to the real world, and then we really need to coordinate the care between the specialist and the primary care. Emphasize the place on collaborating across the care team to provide seamless patient-centered, patient-centric experience. So every single thing we try to do nowadays country to do the seamless, streamlined care for the patient. And so this is that offers the Excelsior and render the opportunity to do the seamless care. And we will talk about that later. And so for the prevention approach, prevention is our doctor's goal. We really want the people be healthy, our patient more healthier. And so this is a prevention is so essential. I appreciate surgeons can treat the hernia, right? And I appreciate the ophthalmologist can treat the cataract, but how to prevent the disease, hernia, no way, right? But we can detect earlier, and the cataract, we can offer the patient more educational advice. So, and there are many things patients in our community, they are, some people, they overuse the pharmacy and they try to get medication, but they underutilize our true patient care. And they don't understand all doctor's advice that much, and even don't follow the doctor's advice that much, because this is our community, a hardworking community, like me, right? 16 days after giving birth to my little one, I started my orientation at Jamaica Hospital. 23 days after giving birth, I started my night float shift the first day. So we crazy people. So don't blame other people. Don't blame your patient not coming to follow the results, because they need money, they need to work, they need to achieve their goals. So I truly understand that. I never blame them. I always say, hey, if we can cancel the or waive certain copay or co-insurance, let's do it. So this is a come to the patient-centric care. You know the people, you understand people, so you want to help the people. And the cost efficiency is definitely capitation. You don't need to find many biller, and you just need to have the patient, the insurance under your name, under the system, under the organization, and then other things just consider quality. How to decrease the cost, how to make the people realize they need to follow our suggestion and give them interaction. That's all. Next slide. So this is a further explanation, then I think we already understand. Next slide. Oh, this is a picture, and this is the preventive care. This picture was taken, I think, in 2018. Yeah, and so that's my husband, Dr. Bao, who used to work a lot and now want to relax and take certain leisure time. And I think as a primary care physician, we both as a primary care physician, and he was about to be a nephrologist just 6 months apart, because I was doing the business not successfully initially. So I asked him to quit the fellowship like me, and but the reason was different. I didn't enjoy the research that much, but as a fellow, you have to research, and also you have to find the field you really love, and also you got experience. Otherwise, you're gonna be suffered. And but he just joined me, and we both started. You're right, from Brooklyn and Flushing, and this is so aggressive. And because I was thinking, I cannot work with my husband 24/7, and otherwise we're gonna be divorced. No kind of attractive things. And so we worked very hard for the first 3 years, and then this is our third office in Flushing Commons. And so we and I believe my sons will remember so many nights, so many days, so many holidays, and spring, winter recess, we couldn't be with them. But like everybody, so once you prepare the medical field, especially when you do your entrepreneur, these things you really need to be aware. You're gonna miss so many family days. But is it value? Is it worth? Is it value there? Let me tell you, it's really worth for you to devote your time. And I encourage so many people to do entrepreneur and also understand the payment, understand the reimbursement, understand ICD code, understand the CPT, understand the PLC was PC. So primary care doctors prioritize preventive measures such as vaccination, screenings, and lifestyle modification. And the primary care physician emphasizing preventive care helps reduce the onset of chronic diseases and minimizes the need for costly intervention later on. Next slide. Okay, that picture was taken in the end of 2013. And when we were preparing these things, people said, Dr. Lu, you got much younger than before when I put this picture in my office. And recently they peeled out from the door during the latest renovation, the third big renovation in the very small office. And so I just put here because today the topic is the era and the value-based healthcare in this era. But this is a kind of another era, okay? And at that moment, I hold lots of dreams, and I think fee-for-service was so good, and I love fee-for-service. And I started, and people told me, as long as you can do procedures, you can collect money. And so at that moment, even I was thinking to do cosmetic medicine. At that moment, yes, I did. I was both. And but that's not the fee for service. That's cash-based medicine. And also, I think as a physician, if we can do traditional insurance-based medicine, do it. If we can do cash-based medicine, why not? So also offer patients improve patients' IQ, EQ, OQ, and BQ. So this is as a primary care, patient-centered care, emphasize patient involvement. And so this patient involvement, so we be very close to the patient. So we need to respect patient decision-making right. So somehow this is a rely on EQ, how to talk to the patient. Why? Because you need to improve your quality. You need to improve the care outcome. You have to convince the patient. And yeah, right. Nowadays, the consideration of preference and the values. The CMS got lots of things nowadays. Get the feedback from the patients, giving the physician scores. So this is a really rely on, first of all, why patients like us, because they like our kind of quality of care, the patient care. We have to treat the patient correctly, precisely, right? Efficiently. And then they love us. They think, okay, this is a reliable person. And then make the people feel happy. That's another thing. Otherwise, they don't evaluate us nicely. So this is so bad. I really hate this evaluation. How can we complete the patient in such rush hour? Not rush seconds. Impossible. But how to make the people feel happy? I think this is rely on the whole teamwork. The specialists, the radiology, get the radiology correctly. Try to find the positive condition and see the cardiologist, get the completed code with the CHF. So these value base, so that's called value. So when we talk about the word value, come to the medical field, you really need to think what the true value. And for in another word is patient complication, but complicity, not complication. So complicity, which means we treat the patient are real patient, sick patients, and with advanced medical need for the government put the money on this patient with certain medical plan and intervention, radiology treatment, surgical procedures, and the care, including home care. So all as primary care, we are doing this job. So some specialists blame the primary care, blaming us, okay, spend too much money on unnecessary medication, on the home care, other things. So we cannot change the whole world. We just need to work involved in the system, try to use our own way and energy to adjust people's missed behavior or direction. That's what I want to do. And so also the patient-centered care also as a consideration of preference and values. So this is the thing is communication is the way is a part of our medical residency training, and communication skills always are very important evaluation for evaluate the residents. And I do the NP student training a lot, and my render team, executive team know that I trained more than 30 nurse practitioner students and some medical school students shadowing in my office, and even some people who doesn't want to do medical field, then eventually end up into the medical field. So when I evaluate the form on the patient evaluation, such as yesterday, I always put communication as the first line. I look at the different school with different forms, then I put communication as the first line. But because I believe a good person with good communication skills gonna do good medicine, because he or she gonna love the people, understand people, get the value down. So this is very important. Patient satisfaction doesn't mean we need to please patient, but we need to use our work, use the patient outcome to please the patient and please the government. Next slide, please. Okay, and in patient-centered care, prioritize the unique needs and preferences of each patient to deliver personalized, high-quality care that improve their overall health and satisfaction. Streamline communication and the collaboration across the care team to ensure a seamless patient journey and better health outcomes. Engage patients as active participants in their care, empowering them to make informed decisions and take ownership of their health. Better health is a goal, not more treatment. Better health is inherently less expensive than poor health. So the healthcare, the inner healthcare is the center of the save the money and save the patient lives. So this is also overall gonna make our job be more meaningful. Next slide. Okay, data is very important thing for you as a young medical professional to know. Data is not the AI data. Data is a patient data, which means how you use your medical knowledge and experience to summarize the patient complexity. And the data so valuable. And every day I feel so pain. I don't know, Dr. Wang suffered recently as in render system. They give us they follow us about our coding of the ICD diagnostic codes. Every day they got every month they give us 2 dates, 93, 85, 65, even 45% score. Everybody feel, oh, which month? Okay, what's my rank? And this is also good thing. Make the doctor working with the patient. Meanwhile, try to code. And without coding, the whole government CMS cannot detect patient condition. And nowadays, the new technique already can make each patient connect to CMS directly. So each single penny they spend on each patient can already be detected individually to one patient, one visit, several seconds. Okay, and so then this is the data analysis also using how many young kind of students knows what the CPT code. Okay, do you know the CPT code? Do you know CPT code? No, okay. So all the doctors know hate CPT code, or love CPT code. CPT code is money, and the CPT code is a reimbursement. They only give us the reimbursement by seeing how we code the CPT. I used to love CPT code so much. Now I hate CPT code so much because CPT also CPT when we give diagnosis, such as we do the COPD, you can do the PFT. The PFT, there are two. It's the 90, I think 94375, 94060. That's a two codes for the pulmonary function test. And so you need to use 94060 on the wheezing, on the exacerbation, and on the kind of advanced disease, and get the pre-post comparison, and they give us more money. And if you use 94375, if you wrongly use that one, they give you maybe 50% of your PFT procedure. And you can now do random PFT on the random person. You have to give reason. But do you want to give a fake reason to do this one? Maybe if you want, somebody want, but depends how you communicate with the patient. Does the patient have any necessity to do the procedure? Maybe who is a secondhand smoker, husband who is a heavy smoker, and the whole family sees us, right? We know the husband smoke 3 packs a day and the indoor smoking. You have to check the wife's condition. So this value-based really means a lot nowadays to me. Before, I was thinking fee-for-service was wonderful. I really kind of against the fee-for-capitation. Now I came to the stage. Maybe somebody said, oh, you have your nice house, you have kids grow up, and you have already car already. So then you want to just focus on that. Yes, you are right. So when we were young, and then we really need to be hardworking and achieve money. And at a certain time point, we need to achieve other things. To achieve is when we see patient, I'm thinking how to make the holistic things together, know the people, know the family, and try to do things where we follow the colonoscopy, mammogram, DEXA, and low dose chest CT. But meanwhile, don't forget the pelvic sono, right? The chest X-ray. These things for those patient essential care. So the data put ICD-10 code, then the CPT for the money, and also the quality code also on the CPT. The CPT makes the government knows, okay, you finish smoking detection, you finish the kind of annual BMI collection, and finish the alcohol consultation. So these things is part of primary care. Be honest, although Dr. Kang doesn't understand the primary care, what they are doing and why they are so busy, right? So there's so much headache for us. And because our work collects surgeons kind of pancreatic cancer, post the procedure, post the surgery, and with certain colostomy and other things. So we really need to put that annually in the chart. So I think primary care really became a essential center of the CMS based. This is called the value-based healthcare. Because we really need to coordinate. You know, CMS at the table, CMS, how many organizations working on CMS? Almost 100. Not only the surgical and dialysis and the ACP, and so many ACP. This is the accountable care organization. Accountable. Value is accountable. Disease cannot be counted. Value. So now everybody understands accountable. Next slide. Okay, time is limited. Shall we move on? Okay, and okay, move on. This is all. Go back. This is our new office opened during the COVID, because I still think that's a part of the reason they asked me render, be the speaker to stand here, give us a talk, because I really kind of have the most clinics in render. So I have full with my husband and the other 2 MD and another 9 NP and PA. We run full clinics in both Flushing and Brooklyn. Also, I have 2 med spa. Yeah, that's my business. And next slide. Data transformation, and no doubt we using Ambiland. So learning using select a good EMR system is a very wonderful way to collect patient data and get the reimbursement done seamlessly. And so I'm not a kind of representative for Ambiland just because I'm using Ambiland. So there are eClinical, other things, EMR, and so knowing billing is one thing you need to do in your residency. Even when you come to medical field, you really need to know a little bit of billing. Next slide. Okay, this is a table. We want to talk about the category 1, and this is a typical fee-for-service level. And and then the link to the quality. And this is this is a CAPA, the CAPA-based care. Because when I was in CAPA, many of us belong to CAPA, and this is give us a certain pay for performance. We're gonna have certain award because we treat the patient better. CAPA give us everybody certain money, and then the payment is due fee for service based, but plus certain awards money. And then the category 3, this is the alternative payment model. Alternative payment model, which means the money payment reimbursement changed. And in this category 3, gonna completely achieve nationwide to 2030, which means before it put 2025, and now they postpone to 2030. That's gonna be the nationwide essential payment way, and gonna be value-based payment essential model, and it's called the alternative payment model, and build up on people service and render using the offset shared saving. Shared saving, which means they give us certain money, and if you have certain risk, which means you can do good or do bad. And so, for example, certain insurance, the patient spends so much money on acupuncture as a primary care, you couldn't treat the patient pain very well, then they give us penalty, which means you have 0 reward, and they give us a little penalty. So this is a shared saving, and do certain risk. We need to share certain risk, but come to the global risk contract. That's the full part of the category. So this category 4, this is a population-based payment. It's also called population global. Think about the Earth, the whole population. It's called global risk contract, which means the government pay $1 billion to one organization, one tax ID, one group of people, and then no matter how you spend money, they don't intervene. And then how to try to save the money and give everybody the money. That's the model. So in 2030, we really need to prepare that. This is the prospective payment. Retrospective payment, which means you did bad, they don't give you a award. But prospective payment, they give the whole up on the millions of dollars, billions of dollars. You just do by your own. All right, the next slide. Okay, conclusion. Dream big, start big. And I started from 2 locations. Now it's 4. And I think I'm gonna stop internal medicine practice over there for no more. But I want to work my future time and on the educational and for the medical field students, residency training and NP program training. And then another thing is do the community health broadcasting talk. That's my next goal to deal with the value-based healthcare era. Thank you so much.